So to begin the cornea section, and thank you for your attendance. I guess there's still is some interest in the cornea as well. That's great. Our first speaker of this section is Dr. Mukherjee from works also with Dr. Ganoum. He'll be speaking on characterization of Fusarium keratitis outbreak isolates, contribution of biofilms to antimicrobial resistance and pathogenesis. Thank you.
Great, thank you for inviting me here. I'm really happy to be here and talk about some of the work we are doing. We are part of the mycology division of Center for Medical Mycology in the dermatology department, and we have a very active and fruitful collaboration with Dr. Perlman, and the work that I'm going to talk about today is a result of that collaboration. So what I'm going to talk about is about Fusarium and how it relates to Fusarium keratitis and the role of Fusarium biofilms in this process and how it affects the pathogenesis and the susceptibility to antimicrobial agents for this organism. Fusarium, as we all know, is a mold. It's present in plants, in fruits, and it causes infections in the plant world as well as in our human world. Most of the pathogenesis is related to toxins that is secreted by Fusarium and is pretty well characterized. Among the infections that Fusarium can cause, it can cause disseminated infection, which would be in mostly in immunocompromised patients, and the range of mortality is pretty high for Fusarium, and which is why it's an important disease to look at. In terms of the eye, it can cause Fusarium keratitis, which is a leading cause for blindness, especially in the developing countries. And in terms of the ratios, the incidence is at least 10 times higher in the South Asian countries compared to the US. The infection is generally related to tropical regions, so and people working in the fields, people in the agriculture area are more at risk to this infection. It's a difficult to treat infection, both in the eye as well as systemically, and the azoles, which are the normal antifungal agents, are not really as effective, while the most common modes of treatment would be natamycin or amphotericin B. Voriconazole has been shown to have some effect in some studies. So even though its prevalence is noticeable, we don't really know much about what's the mechanism by which Fusarium keratitis happens, how it affects, how it interacts with the immune system, remembering that it is a disease in immunocompetent individuals. So one clue came to this was with the when we look at the contact lens related keratitis, and in that respect, there are a lot of contact lens wearers, and people who wear contact lens can be at risk, especially if they are in an area which is, again, conducive to Fusarium growth. In the US, it is generally not that common, which was the accepted knowledge at that time. However, as we recall, there was an outbreak of Fusarium keratitis some time back, which was linked to the use of a contact lens solution. So in this case, there was contact lens related users had infections, as you can see in these pictures, and fungi was isolated and found to be Fusarium. And when there was association between different variables, use of a particular contact lens solution, MoistureLocor in this case, was found to be a significant association with infection. So this paper, which was published in JAMA, and it's kind of summarized all the outbreak-related incidences. And one of the things that the authors came out was that possible reasons for this, or possible fungus-related thing that would explain it, would be the ability to form biofilms, which got us interested in it, because until then we were looking at biofilm formed by Candida in most cases, and in different substrates, including dentures, catheters. So we wanted to see, is the ability to form biofilm possible reason for this enhanced infection with Fusarium also. So we looked at 3 isolates. We used 2 isolates which were clinical and one which was an 80cc isolate, which is recommended as per the standards testing method to be used for all contact lens solutions. Now this isolate was originally isolated in the 1970s in Nigeria, and it's been part of the American type culture collection, so it's the common isolate people would use, and we included that for comparison. We looked at the model we used. These are all in vitro studies at this point. So we used basically contact lenses were soaked with suspension of the bug, and then it was transferred. So the non-adherent cells were removed and transferred to a new growth medium and then allowed to form biofilm. And biofilm formation was assessed colorimetrically by metabolic activity assay, which is the XTT assay, and then also microscopically by either scanning or confocal microscopy. So we found that depending on different types of lenses, and when we compared between Fusarium and Candida, both of them do form biofilm on all the contact lenses. However, the degree differs both by the type of contact lens used as well as the type of organism. So Fusarium versus Candida seem to form generally more biofilm. We looked at the confocal microscopy analysis, and we found that this was similar pattern with respect to the ability to form biofilm, and the architecture was similar, but was different between Fusarium and Candida, but there were some minor differences between the lens types. So some would have more hyphae, some would have less hyphae. In general, Fusarium formed more hyphae. You see more filaments there, and in Candida you don't see as many. However, in Candida and between Candida and Fusarium, there's also difference in thickness of these biofilms. So that's another variable we look at when we are analyzing biofilms, is how extensive the germination is, what kind of morphology is there, and how thick the biofilm is, thinking that thickness would correlate to pathogenicity or susceptibility, which we'll see later may not necessarily be the case. But thickness-wise also, there were differences between the 2 species. So we look at the susceptibility pattern of these biofilms. So using these 3 comparative, these 3 comparators, and we found that in all cases, and this is we're looking at percent growth compared to untreated controls, and all cases when you have biofilm formation, they were less susceptible to the agents tested. In this case, we are testing because we are following up with the CDC studies, we are comparing with MoistureLocor and the MultiPlus solution. And both the lens solutions did not have any effect on the biofilms that were formed. So one potential reason for the reduced susceptibility would be the ability to form biofilms. So then we wanted to expand that principle and look at all the outbreak isolates that were reported by the CDC. So we were able to access those, we were able to get those isolates from the CDC, and we again profiled them for their ability to form biofilms using these colorimetric assays, the microscopy methods, as well as the susceptibility testing methods. So this is the list of isolates we got and their different properties. And this panel shows these 4 panels. They show you, the top 2 panels show you the ability of different strains of Fusarium solani on the left and Fusarium oxysporum on the right to form biofilms. And on the bottom 2 panels are the ability to form biofilm grouped by their clade type. So the top panel is by strains, the bottom panel is by clade. The clades were determined when we had them. These isolates had their identification confirmed by sequencing, and they came out with, based on genetic similarities, there were clade types also, which we found to be varied between these 2. So in general, we found that the Solani species formed quantitatively more biofilm than the oxysporum, and this was between, again, strain as well as clade dependent. So we look at the confocal, we use confocal microscopy to look at the architecture and morphology of these biofilms, and we picked representative isolates. So based on, if you go back from this group, the strain with this panel based on the strain. We picked some that were low biofilm, for example, this 16983, and then there were some that were very high biofilm former. So we picked representative isolates from both the species, both Solani and Oxysporum species, and looked at their architecture using confocal microscopy. In this case, we found that in general, for both the species type, the isolates that formed more biofilms quantitatively also had thicker biofilms, so which kind of agreed and told us that the activity we see in the biofilm is related to the amount of biofilm formed, which is a good measure of monitoring whether there is a difference or not. So next we looked at what kind of susceptibility profile do these biofilms have. Again, they have, okay, the labels are moved up a little bit, but so we looked at, again, 4 different types of, again, the 4 representative isolates, the 2 Solani and 2 Oxysporum. We looked at the susceptibility of these isolates when they're grown as planktonic forms or as biofilms, and what their effect would be to these 3 agents. We looked at amphotericin B, natamycin, and voriconazole. Now, we're looking at MIC, so which is the minimum inhibitory concentration. So the lower the MIC, the more active the drug is. So using that, keeping that in mind, we can see the amphotericin B, for example, the MIC of amphotericin B for these 2 Solani species, when it's grown as a planktonic form, is 1, and compare that with when it's grown as a biofilm, it becomes 128 and 16. So more than, when we're doing the dilution, macrodilution based assays, we're doing serial dilution. So 2 to 3-fold dilutions away is considered to be a reasonably acceptable measure of increase in MIC or decrease in MIC. So by that measure, we are more than 3 dilutions apart, and hence it would be considered to be a reduced susceptibility. But if you look at the voriconazole, between the planktonic and biofilm for these 2 species, these 2 strains, you don't see much difference. So 8 versus 2, 4 versus 8. So in essence, this species, Solani, they form biofilm which are susceptible. They retain their susceptibility to natamycin and voriconazole, but they show reduced susceptibility to amphotericin B. The reverse kind of was the case when we looked at Oxysporum. You had, again, 1 microgram per ml MIC for amphotericin B, which is still in that range when you look at the biofilms formed by these 2 isolates. But if you look at voriconazole, it goes to 256, which is then again in the resistant category. So these 2 species, we see a species-dependent susceptibility. And that's an interesting thing to observe about Fusarium, because for Candida, that's pretty well accepted and well recorded, that the susceptibility of Candida isolates can vary a lot based on their species type, and which is why it's, treatment guidelines also suggest that you should look at species before we choose a particular drug. So in conclusion, so for these biofilms, we have species-dependent antifungal susceptibilities for these 2. And then next we looked at, finally, so we looked at the in vivo virulence pattern for these isolates to see all of these results that previously were in vitro. Does it replicate when we transfer it to an animal model? What we did was we had 2 animal models. We looked at it in 2 animal models. One was where we grew biofilm on a contact lens and then applied it to abraded cornea in mice. And the other was a direct intrasomal injection with the conidia in the same similar animal strains. So looking at the situation where we added the biofilm, we look at ATCC and then compare those with the 2 Solani or Oxysporum isolates. And ATCC isolate form the lowest, or really resulted in the lowest CFU burden, fungal burden. Also, if you look at the pictures, well, we don't have the ATCC picture here, but down here we have basically the ATCC isolate did not form any infection. If you look at it visually, you don't see the opacification of cornea in this case. And you see the lowest number of CFU, baseline CFUs for ATCC, but for the others you see higher. In the intrasomal model, you see all of them having fairly similar CFU in terms of the fungal burden in tissue. So we were looking at these between for their ability to form biofilm. So the thicker or lower biofilm, they didn't really differ much in terms of the ability to infect. So the conclusion we drew from this is that, and because also the ATCC isolate that does not form biofilm did not cause any visible infection, so we drew the conclusion that this ability to cause infection is related to the ability of the organism to form biofilms and not necessarily to its thickness. So that's my last conclusion slide. Again, that the Fusarium isolates do form biofilm. These biofilms show species-dependent susceptibility patterns, and that their pathogenesis is linked to the ability to form biofilm and not necessarily to the thickness. So the biofilm formation ability of these isolates would be an important thing to consider when we look at the infection and management of this particular infection. Any questions, I'll be glad to help. Thank you.